The problem statement today, the number of people blind from cataract is increasing by approximately 1 million per year. Number of operable cataract eyes defined as visual acuity less than 660, increasing by 4 to 5 million per year, and approximately 10 million cataract operations are performed in the world today. The cataract surgical rate is defined as the number of cataract operations performed per million population. In India, the cataract surgical rate is over 4,000. This is a map that shows the Southeast Asian region CSR rates. Now the long journey, I just added a little slide on the history. Before 2000 BC, the Babylonians and the Japanese used to perform couching, followed by Sushruta in India. The earliest written description of self-couching is in the Apocrypha of the Bible. The first to extracapsular cataract surgery was by Daviel in 1748. The intracapsular technique was introduced in 1880 by Smith. 1949, Sir Harold Ridley revolutionized cataract surgery with the introduction of the intraocular lens. Charles Kellman in 1967 introduced the phacoemulsification. Coming to the aim of the study, to evaluate prospectively the operative complications and document the final visual outcome in 164 cataract cases which are operated at Regional Eye Hospital, Warangal, over a period of 3 months by the technique of manual small incision cataract surgery. The materials and methods that were used are prospective analysis of 164 patients. We recorded the complications and the final visual outcome of MSICS with 3CL implantation. The exclusion criteria we used were history of trauma, diabetes, hypertension, presence of anterior or posterior segment pathology where the fundus examination was possible, and the age less than 50 years were excluded. All the patients were given an intraocular power that conformed to the value of the A scan, and all the patients were operated by a single surgeon with an incision size of 6 millimeters, implantation of a rigid PMMA intraocular lens. The intra complications were noted. This is the surgical technique that we follow at REH Warangal with the conjunctival incision, application of the cautery, then the scleral incision is given, sclerocorneal tunnel is fashioned, side port incision is then given, then trypan blue dye is injected into the anterior chamber for staining, and capsular excess is performed to the side port. Entry into the anterior chamber is achieved. Extension of the tunnel is then performed. Hydrodissection is then done. Nucleus is delivered into the anterior chamber. We are using a vectis. We use a sandwich technique for removal of the nucleus from the anterior chamber. The cortical matter is washed with a Simcoe cannula, and a rigid PMMA intraocular lens is then implanted into the capsular bag. Dialing of the intraocular lens is done. The remaining viscoelastic is washed from the bag and the anterior chamber. And finally, we apply a cautery, and the subconjunctival gentamicin injection is then given. Yes, the patients were then followed up for a period of 6 weeks after surgery, and the post-op complications, the final visual outcome. That's the best corrective visual acuity using the Snellen's chart was recorded. We used tumbling geese for the illiterate and the Snellen's chart for the literate. Among the results, 57.9% were male, 42.1% were female. The mean age at operation was 63.86 years. The eye operated, majority 53.7% were operated on the right eye, 46.3% on the left. And among the types of cataract, 57.3% comprised of the immature cataract, 31.7% mature, and the rest comprised of the nuclear cataract, which was 11%. In the intraoperative complications, we had 3 cases of posterior capsular rent with 1 case with vitreous loss, 1 iridodialysis, but the intraocular lens was implanted in all the cases. Among the postoperative complications over a period of 6 weeks, the highest, we had 7 cases of atonic pupil comprising of 4.2%, with peaked irregular pupil 3%, 2 cases of PCO and 1 each of post-op iridocyclitis, 1 iris prolapse and 1 cortical matter. Among the final visual outcome, between 6.6 and 6.9, we had 80 cases, that is 48.8%, 6.12, 6.18, 38.4%, and 3 cases achieved less than counting fingers 3 meters. As atonic pupil was the most common complication, I just briefly touch upon it. It can be a disturbing complication for both the patient and the surgeon. Our criteria included mid-dilated pupil, size equal to or greater than 6 mm, non-reactive to light or accommodation, and 2% pilocarpine drops. The pupil dilates with mydriatics, and the iris shows no evidence of mechanical trauma. The incidence, according to literature, Golik and co-workers reported an incidence of 0.19%. Halpin and co-workers reported 2.29% after ECC. The incidence is difficult to estimate as many cases go unreported. Among the etiology, it is still unclear. The proposed theories include indirect damage to the iris sphincter muscle, possibly caused by increased intraocular pressure, inflammation, toxins, distal pressure and ischemia. Currently, it is believed that iris sphincter ischemia is the final common pathway in the pathogenesis of atonic pupil, but the etiology may vary. We believe manipulation of iris during cortical matter wash or delivery of big nucleus through constrictor pupil may cause mechanical stretching of the iris. Treatment, it's treated conservatively as long as there's no symptoms like glare. In rare cases, a pupilloplasty technique has been described by Osher. It may be performed. Rural review OP, what to expect? This is our experience where patients are lost in follow-up. Irregular follow-up include factors like distance, non-availability of caretaker, lack of finance, medication defaulters due to lack of finance, irregular use of medications, lost dirty discharge cards, non-use of protective eye shade, use of pre-op spectacles due to ignorance and illiteracy is one factor where they complain of visual blurring. And hygiene of the patient especially is very important, as most of our patients are farmers or shepherds or even beggars in a rural setup. Take time out to educate the patients about these factors that will help us achieve good compliance in both use of medicines and follow-up post-surgery. Among conclusions, the final visual outcome for manual SICS in our study was between 6.6 and 6.18 was 87.2%. In a developing country like India, where the unmet need of cataract surgery is large, manual SICS is a vital technique that can be learned and utilized for the benefit of the patients in need. A special mention in rural setups, regular follow-up, verifying post-op medication, and identifying medication defaulters for lack of finance is very helpful. And the common intra-op complication was posterior capsular rent, and the commonest post-operative complication was atonic pupil, as documented in our study. Over the period of few days, we've seen many excellent surgeons and many new techniques, but at the end of the day, I think the smile on the patient's face is what we all look for. Thank you so much. Thank you for your attention.